Hello friends, today we are going to learn about how to approach a neonate with respiratory distress. The topic is very important as both undergraduate and postgraduates may get a long question in theory exam. PGs in fact may get a case in practical examination as well. And more importantly, it is a very practical topic as majority of the newborn in NICUs are admitted with complaints of respiratory distress and you should be able to make a probable diagnosis. Finally, it is a high-yielding topic for the MCQs as well, as many case-based MCQs are being asked from this topic. So the learning objectives for these sessions are, we will learn about the definition, the etiology of respiratory distress in a newborn, individual causes, approach to respiratory distress, how to assess these babies, and finally a case scenario. So the NNPD or the National Neonatal Perinatal Database defines respiratory distress as any one of the following: either the respiratory rate of more than 60 per minute, subcostal or intercostal retractions, or expiratory grunt. Cyanosis may or may not be present in a case of respiratory distress. So let us look at one of these video first. So this is a video of a newborn admitted with complaint of difficulty in breathing soon after birth. So what is your impression? So you can clearly make out that this neonate is tachypneic and is having severe subcostal retractions. Let us look at another video. So this is a 28-day-old neonate who was brought with complaint of cough and coryza for past 2 days. So you can observe that this neonate is having a normal breathing pattern. There is no fast breathing or retraction. You have to count the breaths for full 1 minute because the neonates may have periodic breathing. So there are episodes of fast breathing followed by a period of apnea, but that is considered as normal for a newborn. Let's look at one more video. Right. So this newborn is not having fast breathing, right? But there are subcostal and suprasternal retractions. This is a kind of labored breathing, right? You may have noticed that there are suprasternal retractions as well, suggestive of upper airway obstruction. So now you have seen different kinds of respiratory pattern and different presentation of respiratory distress. Now the question is that what can lead to respiratory distress in a newborn? Although respiratory or the pulmonary causes are responsible for majority of respiratory distress in a newborn, other systems may also be involved. Like there can be cardiac causes, there can be CNS causes like perinatal asphyxia or intracranial hemorrhage, hematological causes like polycythemia or severe anemia, GIT causes like necrotizing enterocolitis or abdominal distension from any cause, surgical conditions like tracheoesophageal fistula, congenital diaphragmatic hernia, bilateral choanal atresia, congenital lobar emphysema or secant, and then there are miscellaneous conditions like hypothermia, shock, or metabolic acidosis can also lead to respiratory distress. So we should not be only focused about the pulmonary causes, but we should do a general examination of a child and should look at other causes responsible for respiratory distress as well. Now we will look at these most important conditions one by one. So first we will talk about respiratory distress syndrome or hyaline membrane disease. So the respiratory distress syndrome or RDS occurs predominantly in preterm newborns, and almost 50% of these newborns are less than 28 weeks of gestation. It is very infrequent after 34 weeks of gestation. The disease is a result of surfactant deficiency, and surfactant is produced by type 2 pneumocytes, and the synthesis usually begins by 20 to 24 weeks of gestation, but mature levels of surfactant are reached only by 34 weeks. So what does surfactant do? Surfactant reduces the surface tension and prevent the collapse of alveoli. In absence of surfactant, the alveoli will collapse and lung will go into atelectasis. So how will a child will present? The newborn will have nasal flaring, grunting, cyanosis, they may be tachypneic, and there will be retractions, intercostal and subcostal retractions. So how do we establish the diagnosis of RDS? So in a premature baby who develops respiratory distress within 6 hours of birth with characteristic radiological features, we can confirm the diagnosis of neonatal RDS. So what are the characteristic radiological features which you can see in a case of RDS? So there will be white out lungs. So as you can see in these pictures, the lungs are completely white out. You cannot visualize the lung. Or there is ground glass appearance. By that we mean that there is a generalized haziness of the lung field. The lung volumes can be low, and you can also see air bronchogram. So this is a very typical case of X-ray of a child suffering from respiratory distress syndrome, where you can see white out lungs. You can also make note of an endotracheal tube in situ, an OG tube in situ, and also there is an umbilical venous catheter going just above the diaphragm. Now, how to assess the fetal lung maturity? So there are various tests which are indicated to assess the fetal lung maturity. Of these, noteworthy are lecithin sphingomyelin ratio or LS ratio. A value of more than 2 is indicative of low risk of RDS. Lamellar body count, fluorescent polarization test or elevated surfactant to albumin ratio, and shake test. All of these tests are performed on amniotic fluid by amniocentesis. But shake test can also be performed on gastric aspirate. So how do we perform shake test? So 1 ml of gastric aspirate or amniotic fluid is mixed with 1 ml of 95% ethanol. It is shaken for 15 seconds and then allowed to stand for 15 minutes. Then you have to note the amount of air bubbles, and if the air bubbles you are able to see the air bubbles, then the risk of RDS is very low, right? So this is of mainly of theoretical importance, but has been sometimes asked in MCQs. So we should know what is the importance of shake test to assess fetal lung maturity. Now, how do you treat these babies? So treatment consists of supportive management and specific management. In supportive measures, we have to stabilize the baby, maintain their temperature, and provide them adequate fluid and nutrition. The specific management include continuous positive airway pressure and surfactant administration. So how do we provide them? CPAP or continuous positive airway pressure. So in CPAP, I'll be making a separate and detailed video on the use of neonatal ventilatory devices, but broadly this is how a CPAP functions. It has a nasal interface, right, and a CPAP machine. So CPAP machine is nothing but a circuit through which you have to provide heated and humidified gases to the infant. The most important component of this CPAP machine is this water column, right, where the expiratory tubing is submerged. So basically the neonate is breathing against a pressure, and this pressure helps in keeping the small airways and alveoli open. Because surfactant is primarily caused by surfactant deficiency, the administration of surfactant directly into the lungs can cure the disease, and we usually use the INSURE technique. INSURE technique is short form for intubation, surfactant and extubation. So we only intubate them briefly just to administer the surfactant and quickly extubate these babies. It has been shown that when you give surfactant to these babies, it reduces the mortality. The only side effect is that surfactant is usually very costly. Can RDS be prevented? Yes. If a delivery is anticipated before 34 weeks of gestation, maternal steroids can be given to the mother, and which will enhance the fetal lung maturity, and RDS can be prevented. The complete course comprises of 2 doses of betamethasone 12 mg IM at 24 hours apart, or 4 doses of dexamethasone 6 mg intramuscular at 12 hours interval. Now, another common condition which can lead to respiratory distress in a newborn is meconium aspiration syndrome. Again, so meconium aspiration syndrome, again the baby will develop respiratory distress soon after birth, and it is seen in a term or post-term baby. So unlike RDS, which was commonly seen in a preterm baby, meconium aspiration syndrome will be seen in a term or a post-term baby. This baby will have meconium stained amniotic fluid, but please remember that not all the babies who have meconium stained amniotic fluid will develop meconium aspiration syndrome. Rather, only 5 to 10% of these babies will actually develop meconium aspiration syndrome. So what happened? This meconium get deposited in the airways and alveoli. In airways, it can cause obstruction, while in alveoli, it can cause chemical pneumonitis leading to alveolar inflammation and edema. Clinical features, apart from the classical features which we noted in the case of RDS also, so there will be nasal flaring, grunting, etc. But there will be some additional features. So what additional features you will get in a typical case of meconium aspiration syndrome? So it will be a term or post-term baby, and then there will be evidences of meconium stained amniotic fluid. So what can be those evidences? So there will be a baby, right, who is meconium stained, but sometimes it may happen that baby is brought late to you, right? So baby has been cleaned, but you can still notice there can be a meconium stained umbilical cord, right? What are the typical radiological features? So you will see heterogeneous opacities in bilateral lung field or patchy infiltrates. There will be area of atelectasis. Air leaks are very common in this meconium aspiration syndrome. So air leaks like pneumothorax or pneumomediastinum can also be seen. Treatment routine suctioning is not indicated in every case of meconium aspiration syndrome. Supportive management in form of maintenance of temperature, IV fluid and oxygenation is to be provided. Antibiotics are usually administered to cover superadded infections. And as there can be secondary surfactant deficiency due to surfactant denaturation by meconium, therefore administration of surfactant may be beneficial to these kids. Final condition which we are going to discuss in today's session is TTNP or transient tachypnea of newborn. This is also known as wet lung syndrome and results because of delayed resorption of fetal lung fluid. The condition usually affects term or late preterm babies and is more commonly seen in infants delivered by cesarean sections or precipitous labor. Now, in the intrauterine life, the lungs are filled with fluid. When the child is delivered by normal vaginal route, there is mechanical drainage of this fluid by squeezing action, and also epinephrine surge during vaginal delivery lead to increased resorption of this lung fluid. However, when there is a C-section or there is a precipitous labor, as may happen in multiparous women, the neonate does not undergo this normal transition of fluid and the fluid is retained in the lungs, leading to respiratory distress. This is a self-limiting condition, but it is a diagnosis of exclusion. The X-ray will typically show fluids in the interlobar fissure and there can be mild pleural effusion as well. Patients usually make a good recovery within 48 to 72 hours as the fluid gets resolved, but other causes you need to be ruled out. Now, how do you approach a typical case of respiratory distress? You have to take a good history, do a proper physical examination and make note of all the signs of respiratory distress. You have to make a list of differential diagnoses and order relevant investigations, relevant radiographs. Then you achieve final diagnosis and treat the patient accordingly. Now, how can we assess respiratory distress? So there are two objective scores. One is Downey score, other is Silverman-Anderson score. So this is a typical Downey score. The component of a Downey scores are respiratory rate, retractions, air entry, grunting, and cyanosis. Right? The score is given from 0 to 1 to 2 for each of these parameters, and you can see the score of more than 7 is indicative of impending respiratory failure. While Downey score is typically done for term babies, Silverman-Anderson score is done for premature babies. The component of a Silverman-Anderson scores are upper chest retraction, lower chest retraction, xiphoid retraction, nasal flaring, and grunting. Again, a score of more than 6 is impending of respiratory failure. Now, sometimes you can get confused between these two scores, that is, what components are there in which score. So, how to remember that? So, you can remember that there is only one R in Downey score, so only retractions is coming only once in a Downey score. while R is coming thrice in Silverman-Anderson score. So retractions are coming thrice in Silverman-Anderson score. Grunting is common in both the scores, and silver ring is usually wearing nose, so you can remember that nasal flaring is a part of Silverman-Anderson score, right? Now let us look at a case scenario. A newborn is delivered at 30 weeks of gestation and he developed respiratory distress soon after birth. Now how will you approach this case? The antenatal history in this case was uneventful, but mother had leaking PV for past 24 hours. So your usual differentials are either it can be a case of TTNB or meconium aspiration syndrome or RDS or pneumonia. Now let us analyze the case one by one. So antenatal history, as we have been told, it is normal. There is one risk factor for sepsis present in this kid, that mother had a leaking PV of past 24 hours. Gestation wise, the baby is premature. The mode of delivery is vaginal. Meconium strain liquor is not present. And the baby developed respiratory distress soon after birth, right? So TTNB is unlikely in this patient as the baby is premature. There is no history of meconium aspiration strained amniotic fluid, so mass is unlikely. RDS and pneumonias are our two possibilities. Now when you ordered the chest x-ray, you are not getting a typical whiteout lung or ground glassing. What you get is the left upper lobe collapse, or you can see a homogeneous opacity in the left upper lobe, right? Also the TLC is low on the lower side, so there is leukopenia, and the CRP is high. So all these parameters are suggestive of early onset sepsis with pneumonia in this patient. So we make a diagnosis of congenital pneumonia. So this is how you have to proceed. You make a list of differential diagnoses, you rule out some based on the available information to you, and then you proceed with the investigation just to confirm your diagnosis. So in this case, how should we proceed? We have to send a blood culture, start the patient on empirical antibiotics, and once we receive the full blood culture report, then depending upon the sensitivity pattern, we have to upgrade our antibiotic. Supportive management will continue in form of IV fluid, oxygen, or temperature maintenance. So if I have to summarize, any patient, any neonate who's coming to you with respiratory distress, you have to see whether you are dealing with a preterm baby or a term baby. In a preterm baby, if the distress is appearing within 6 hours of birth, then the first diagnosis you will keep is respiratory distress syndrome or HMD. Then you can keep the differential of pneumonia or lung anomaly or shock. If the distress is developing after 6 hours, then in a preterm baby, HMD is virtually ruled out. These baby will not develop distress later on, right? Then pneumonia become your prime possibility. Otherwise, you can keep a possibility of congenital heart disease or pulmonary hemorrhage. If you are dealing with a term baby and the baby developed distress soon after birth, that is within 6 hours, then you have to keep a possibility of TTNB or meconium aspiration syndrome. Birth asphyxia, shock, and lung anomalies can also lead to distress. If the baby is developing distress later, more than 6 hours after birth, then the possibility of pneumonia or other causes like polycythemia or CST have to be kept. So this is all for this session. You can subscribe to our videos for more such, subscribe to our channel for more such videos, and we'll be keep on posting more educational videos for pediatric students, for both undergraduate and postgraduate students. Thank you so much.